Hi, my name is Travis McVeigh. I'm an anesthesiologist from Dallas, Texas. I host a podcast called Thank You Notes at Ars Longa Media. Showing gratitude to people just makes me feel good, and I want to share the practice of thank you notes with everybody who listens. I write thank you notes to people and then bring them on the show to read it to them. Past guests have included my high school teachers, my friends, other physicians, and a couple of internet celebrities. I will also be doing episodes that explore the science behind gratitude practices to demonstrate to everybody the actual tangible benefits of practicing gratitude. Listen everywhere you get podcasts and check out the extras on my social media accounts. Thank you for listening.
Welcome to the Inside the Boards Study Smarter podcast. I am Patrick Beeman, your host. This is part 2 of our internal medicine cardiology review. We're going to get right into the content after the intro, but just a reminder, go to our website, insidetheboards.com, sign up for our email list. We are going to be having an enhanced version of Step 2 Secrets with me and Ted O'Connell, the author of that book, which will be released in our beta iOS app, which is due out any day. As well, we've got a few other things coming down the pike for you, so sign up. Tell your friends. Thanks for listening.
Welcome to the Inside the Boards Study Smarter series, dedicated to helping you learn to think like a question writer, so you can study smarter, not harder, and succeed on your exam.
A 67-year-old male presents with substernal chest pain that's crushing in nature and is not relieved by rest. He is pale, cool, and diaphoretic. He received aspirin and nitroglycerin by the emergency medical services. His vitals are a heart rate of 110, respirations of 24, and a blood pressure of 90/60. His EKG shows ST segment elevation in the inferior leads, and importantly, the nearest facility with percutaneous coronary intervention capabilities is 40 minutes away. What is the best next step in this patient's management? Is it A, intravenous abciximab? God, I love saying that. What a cool word. B, serum troponin. C, intravenous streptokinase. Or D, emergently transport the patient to the nearest facility with PCI capability. All right, so let me see here.
An inferior MI.
Inferior, yeah, let's break it down.
Diagnosed by EKG.
So we can ignore all that stuff that comes before because we have the diagnosis. ST segment.
They told you what's going on here, and they're asking, what do we do next?
Yep. So 40 minutes. I bet that's important.
Yeah, so that really comes into our time of like how we're going to treat this, right? 40 minutes, that's not too long, especially if this person just now started having this chest pain. We've already talked about 90 minutes being an important time for us to get somewhere, or once we're in the door, right? Yeah. And I mentioned that, that time starts when you get to the hospital. 40 minutes, I think, is fair. I think, honestly, given... I think 40 minutes is probably shorter than a lot of people give it credit for. I think they would think that, oh, that's a long amount of time. I actually think that's kind of short. So I would say let's go to a facility that can help this patient appropriately and get our percutaneous coronary intervention, right?
Boom, and you are correct. So the patient's having a STEMI. Door to balloon time is 90 minutes. That's what you're looking for on the exam. So if he gets transported over to the facility that has a PCI capability, then PCI is the right answer if it's less than 60 minutes from a PCI facility.
Yeah, if we're further out than that, is that when we're going to consider using like a clot busting drug,
like streptokinase?
Yeah.
Okay. All right. What about things you would do as best next steps in management if they listed, say, transport to a facility with PCI capability, streptokinase, and say low molecular weight heparin?
So low molecular weight heparin, we're considering taking them to a facility where we're going to do an intervention on them, where we're not going to want a anticoagulant therapy on board necessarily. And if we have time, something like low molecular weight heparin, it prevents new clots from being formed, but it doesn't get rid of clots that are already there, for instance. So that's not going to be too helpful for us, right? I would rather us just hold that and let's go.
Okay, so it doesn't change if heparin is one of the options in terms of the best next steps.
Yeah, the problem, it could be given. I don't think you could have both answer choices though. They both couldn't be correct, right?
Right.
So if you took off the transport, or if you say they're going to be transported, then that could be a choice, right?
Yeah.
So if that was in the vignette where they're going to be in a facility in 40 minutes, what do you do while they're waiting? We can go into the whole like Monabash interventions that we could go through for this patient at that time.
Which, for those who have not yet studied that in their third year clerkships, what exactly is that?
So Monabash is a bunch of drugs that we can give for an acute coronary intervention, I guess, right? So we're going to start, I don't particularly like the order of them. So don't use it for the order, but the mnemonic goes morphine, oxygen, nitrates, nitroglycerin, aspirin, a beta blocker of some sort, ACE inhibitors, statins, and heparin. You can add an A for like just general anticoagulation, right? The reality is you're going to give this patient oxygen. You're going to give them aspirin and nitrates, right? You're probably going to start some more anticoagulation therapy like Plavix or clopidogrel. You might give them a heparin drip at the time as well. Morphine is for treating their pain, anxiety, which can also, there's some evidence that can make them less stressed about the pain and can relax them a little bit, which is a problem when you're having a heart attack, is you're not relaxed, and that can lead to more damage, right? Because you're trying to have more cardiac work while you're under stress, right? Yeah. There's like a catecholamine response that can be, if you can tamper that down, you might help them in the long run. Nitrates, cause some vasodilation, which will help with the arteries if they are amenable to opening. Beta blockers to control rate, also get the blood pressure down, right? Statins and, like an ACE inhibitor, those are going to take some time to work. So like those are kind of lower down on your list when you're starting them, but they're on that. They're part of that workup as well.
All right. What about this? Let's say the vignette's the same. You got a dude who's got a STEMI and you're 40 minutes away from a PCI facility, but his history is positive for congestive heart failure. how would that change the management?
Ooh, that's kind of getting over my head at this point. So if he's in heart failure, right?
All right, so let's say this vignette were a little bit different. You've got a person with a STEMI, right? And the PCI place is 40 minutes away. But instead of what is the best next step in management, we've got an interrogatory that is, which of the following treatments is contraindicated? And importantly, the history mentions this patient has a diagnosis of congestive heart failure. And your answer choices are A, PCI, is that contraindicated? B, beta blockers, is that contraindicated? 3, or C, aspirin, is that contraindicated? Or D, morphine, is that contraindicated?
So I'm kind of between the beta blocker here with heart failure, right?
And what else?
The morphine bugs me a little bit too. If they're already if they're in heart failure and they have they've got crackles in their lungs, they're probably not breathing too well, and we're going to decrease their respiratory drive. That could be kind of dangerous for them as well. Beta blocker decreasing their cardiac output, which is important for the heart failure patient. You're kind of having to balance that with the fact that their heart is under strain and stress right now, given that they're having their heart attack, right? So those are two I have trouble reconciling those two meds for the patient.
So you'd say beta blockers contraindicated?
Yeah, I would avoid it.
Correct. So that's just what I was getting at. One other little, learning point here is someone's got a STEMI and CHF, then avoid giving them a beta blocker in that acute emergent setting.
Yeah. Chances are they've already taken a beta blocker during that time period too.
Right, exactly. But this is a testing environment. It's black and white.
Exactly. Very, very no gray zones here.
Amen. All right. Want to move on?
Yeah, I think we've beaten that a little bit.
All right. So
let's go.
Our final one for this cardiology review is, well, why don't you go ahead?
All right. We may have touched on this a little bit, as you can imagine. So, a 45-year-old man comes in for a non-ST elevated MI. He has a heart catheterization, which reveals non-obstructive coronary artery disease. No stents are placed. He is arranging discharge at this time. What medications are indicated for this patient on discharge?
Ooh.
Is it A, aspirin, a statin, beta blocker, an ACE inhibitor? B, aspirin, statin, beta blocker, and calcium channel blocker? C, nitroglycerin, aspirin, beta blocker, and ACE inhibitor? Or D, nitroglycerin, statin, beta blocker, and ACE inhibitor?
Oh.
That might be a little tough to grapple from an audio standpoint, guys. So
basically the differences are A and B, you give aspirin, statin, beta blocker, but with A, you also give ACE inhibitor. With B, you also give a calcium channel blocker. And then for C and D, you're giving a nitro, beta blocker, ACE inhibitor, plus for C, aspirin, or for D, plus a statin.
Yeah. So all of these are pretty good drugs. Patrick, which one are you going to give them?
All right. Well, I mean, after you ran through the Mona Bash mnemonic, which 10 years ago was just Mona in my medical school training. So I'm going to go with the one that has the most of, or the ones that have the most of those. So I'm going to rule out B because calcium channel blockers, I don't know, in a lot of contexts seem like just symptomatic kind of treatments and or second lines for various things. And so that leaves me with, let's see, he's got an N-STEMI, and so nitroglycerin is it true that I can say this is essentially kind of like stable? No. I'm inclined to say A, the aspirin statin beta blocker ACE inhibitor combo, but I'm not quite sure why not to give nitro.
It's tough. So, right, like which ones, I guess the question really then is making you really delineate, does this patient need either a statin or nitro?
Yeah.
In this case, or aspirin and
I'm going to say
nitro, right?
Yeah.
And you're going with aspirin, statin, beta blocker, and an ACE inhibitor. And I think that's fair because I don't think, if you were to give them nitro instead of a statin, like a statin is going to have good utility for helping stabilize like vessels, preventing future plaque rupture, right?
Yeah.
Nitro is more for relieving like angina symptoms. This person's already had their unstable, they've had an N-STEMI, so they're beyond that at this point. It might be good to give them that if they do experience anginal pain, but that one is sort of up in the air as whether or not they need it, right?
Yeah, because
on the other hand,
are they, if it's unstable angina, like, and you give them like nitro, is it really going to help?
Mm-hmm. Exactly.
All right.
So it kind of beyond that point, honestly, at this point. And then to sub it out or to give that instead of aspirin, I think would not be useful. Recently, there was actually a study that was saying you should no longer, what is it? I think aspirin should only be used for secondary prevention. This patient doesn't meet the age criteria, but if someone has had symptoms, like they would be a good patient to have on aspirin. There were recent literature suggesting that maybe you shouldn't have them on a statin or an aspirin regimen for primary prevention, though. But that's not this case. We've already had our heart attack.
Yeah.
And we're trying to prevent future heart attacks, right?
Yep. All right. So, N-STEMI, about to be discharged, non-obstructive coronary artery disease, aspirin, statin, beta blocker, ACE inhibitors.
Mm-hmm.
All right. Anything else on this one?
No, not that I can think of. One thing that I'm trying to remember for the last question we were talking about, they had an inferior MI and they were given nitroglycerin. Did you ever learn that you shouldn't do that?
No. Did you?
I think that's come up a couple times where they say, if you're having an inferior MI or like a posterior vessel disease, giving nitroglycerin can induce like a severe hypotension. And that is how that patient presented. And And I'm trying to remember what the reasoning behind it is. We'll have to get back to things on that, right?
I mean, so far as nitro goes, I don't know that I actually learned this, but I did look it up, and nitro is contraindicated in a right inferior wall infarction, and instead you just give fluids to maintain the blood pressure. But I'll be frank, I don't know if that applies to all inferior wall infarctions. But at least we can say for a learning point, it's right inferior wall infarctions.
Yeah. So what I'm thinking happens if you give nitro, you end up causing hypotension, and you decrease, like, you basically add like heart failure on top of this patient, right?
Yeah.
So now they're not pumping blood as well, because if they're having an inferior MI, that's going to be related to their left ventricle, right?
Mm-hmm. All right.
So if they stop pumping blood, we have problems.
Agreed. All right, that makes sense.
So we need to give them fluids in that case to keep their preload up, so they continue to perfuse. And if we give them nitro, we might decrease their preload on top of this, right?
Yep.
I'm thinking that's the reason, but I'd have to look back through my notes.
Okay. Well, I don't know. I would say just there's your homework assignment. We're going to start giving homework assignments for anything that we're not sure on. So there's your homework assignment. Is it all inferior MIs or just right-sided inferior MIs?
Mm-hmm.
All right. That's it. Subscribe to our all audio QBank. Just go to InsideTheBoards.com. Thanks to Online MedEd for providing this content. If you have not yet bought your Online MedEd subscription, and we know you're going to use it like 80% plus of third-year medical students, click the link in the show notes to sign up, because they give us a little bit of a kickback for doing so, which helps us continue to create this content, especially pay for the editing of these, which allows us to just record and get you more content rather than have to sit there and tediously edit this, which is probably not the best use of either mine or Stuart's time. Today's music is by DJ Bezo, aka Augustin Beeman. The song is King Jeff and His Apprentice Bart. We'll be featuring more from this young emerging artist who also happens to be my son. I'm just really proud of the creative work he's doing and wanted to support him in his endeavors. So thank you, Augustin. We'll look forward to more of your art, which we'd be happy to feature on the ITB podcast.